Everybody. I hope that everybody had a safe drive in this morning. We're going to get started with Dr. David Miranda. He is one of our senior fellows, and I think this is going to be probably the last time that you speak before you move on.
My last time, yes.
Okay. So anyway, we welcome Dr. Miranda.
Good morning. Everybody can hear me okay? So thank you, Jillian, for the introduction. So yes, this is my last grand rounds here at MHI's Cardiology Fellow. So today I want to talk about lessons from a busy weekend, and it's a case carousel that I was involved in just one weekend. And the main three reasons I want to present these cases is because it was a very complex decision making, one. Then two, as I said before, only in one weekend. And then three, involve a lot of critical care cardiology and advanced heart failure stuff. That is what I'm interested in. So go ahead and start. So the three cases we're going to review is one of a 49-year-old male that was playing hockey. And this one will be on peripheral BA ECMO. The second one is a 27-year-old female. She was previously healthy, 31-week pregnant, and she presented with fever and malaise. And in this case, we're going to review the post-cardiotomy shock, a little bit of central VA ECMO cannulation, and we're going to review a little of the MHI data on ECMO. And then the third case is not specifically on ECMO, but it's a 39-year-old female, also along the same theme, 36-week pregnant. This is her third child, and she presented with chest pain. And at the end of the weekend, I was like, can't believe this all happened the same weekend. So, okay, so case number one, as I said, this is starting my interventional rotation in the Cath Lab, and we have this guy, 49-year-old male, no prior cardiac history. He's very active. We talked to his wife and after the fact and all that, and apparently he played hockey with friends before going to work, and he did this like two or three times a week. But then when he was not doing this, he was either in the gym, and he worked like, he has a very active work as well. So after the game, and we knew this afterwards, after the game, he finished and he had chest pain. So because it was so early in the morning, instead of going home, he drove himself to St. Francis Regional Medical Center with chest pain. So while he was driving, apparently the security staff saw that he was driving into the parking lot, the car hit the curb, and then he hit a snowbank that was there. So security staff came out, they found him unresponsive, he was having this seizure-like activity, so they break the window, they pull the guy out of the car and take him to the ER. And this is all, and this information we got, it was like, wow, this really happened. So this is a summary of the rhythm strips that they had at St. Francis Regional Medical Center. And I put this here because to see that he had a total of 9 shocks. And when they put him on the monitor, this is he was in ventricular fibrillation, and here's a shock. But to summarize the events, he got resuscitated after 9 shocks. And this part of the rhythm strips that he got, so he had some agonal breathing, he got a pulse at some point. They said, let's put a Lucas device and let's send him to Abbott because he was going in and out of this malignant arrhythmia. So they send it down here for consideration of VA ECMO. At this point, when we got like the sign out, it was unclear what was the etiology. And when we see the medications that they gave him, Ativan was the first thing that the working diagnosis that they had at the beginning was that there was a seizure instead of a cardiac event. Obviously, as they worked on him and that he didn't have a pulse because of his age and the recurrent ventricular fibrillation, they said this is probably a cardiac event. But we never got an EKG at that point at St. Francis. And the first EKG in his chart is like after the Cath Lab. So he got the appropriate ACLS medications, as I said, 8 shocks and then 1 en route. So total of 9 shocks. So this is my first day in the Cath Lab rotation with Dr. Carousel. I'm there in CV7, still remember it. And they're willing this patient, Lucas is in place. The EMS staff is just like very anxious, like wanted to deliver this patient. Blood pressure is 90 systolic, that's all we get. He's intubated, he's mildly sedated. And this will be important for later, for some of the things that happened, the sedation, because he had, I mean, it's always good when you see a patient that had a cardiac arrest but has some spontaneous movement from a neurologic standpoint. But this created a complication that we'll talk a little bit later. So he has cool and clamp extremities, clearly in cardiogenic shock. So at this time, we decided to proceed with a VA ECMO. So the cannulation was done first. So the 8 line was in the left femoral artery, so 17 French sheet. And then in the right vein, we put the drainage cannula that is a 25 French. After the case, after we're done, we put an intra-aortic balloon pump in the right femoral, but obviously this was done after the case because first we want to do the diagnostic angiogram. So I showed the right coronary artery first because I want to show that he was already supported when we did the angiogram. So this is the drainage cannula in the vein. So the right coronary artery doesn't have any coronary disease that we can see. But then if we go to the left system, there's a stump in the LAD, proximal LAD, that we immediately identify the cause of his cardiac arrest. So obviously, intervention was done. He had good flow afterwards, and we aspirate a clot. And this picture was important for as part of when we explained to the wife, we had this picture available, and we couldn't believe this almost caused her husband dying. So we did the thrombectomy. In the Cath Lab, we gave aspirin. The patient was loaded with ticagrelor. Just because of the concern of the absorption and in the cardiac arrest and the hypotension, we gave a cangular load and the infusion. And vascular surgery was called in the room. And this is what I wanted to say about the sedation. So after he had the cannula placed and we intervened on him, the patient started to sit up, and the cannula in the artery came out a little bit, and that created significant bleeding in the arteriotomy site. So we later discussed in the ECMO meeting, in like the review of the cases, that the patient was not properly sedated, probably caused this issue. So as I said, vascular came, did a cut down, control the bleeding, but it was not very significant, but it was something that, you know, we review it, we can improve. Hemodynamics after the VA ECMO support was placed. His blood pressure was 86 over 60 with a mean of 67. That is pretty good for ECMO support. He had a wedge of 18 with a CBP of 12. Not normal, but pretty good for how he came initially. His cardiac index was 5.4 on ECMO support, and we have him in a pump flow of 3.2 liters with a sweep of 2.5, and an excellent PA-SAT of 84.6. So when he left the Cath Lab, he was at least stable from a hemodynamic standpoint. So one of the things that I thought was really educational for me is that I was involved in this case from the beginning in the Cath Lab all the way to when I saw him in clinic. But one of the main things that I thought it was really good is for me as a fellow at least, was go with both Dr. Gossel and Dr. Granowitz and go and talk to the wife. Delivering news is something that was really beneficial in, I think, during that case from an education. So echo, we have limited views because of ECMO, difficult windows. CCF was around 10 to 20%. And obviously, because of the cardiogenic shock, we had AKI, shock liver. Full pressure was really, it was 15 to 20. So we started him on the butamine and dopamine to enhance some LV fraction, LV ejection. In the echocardiogram, we saw that the aortic valve was not opening with every beat. So just as a follow-up, 48 hours post the event, he was successfully decannulated. We struggled a little bit with the bleeding in that left femoral artery because of how when he moved in the arteriotomy side. He was following commands. Other than some issues with eating and brushing his teeth and some, you know, his wife said that he was a little bit slow for what she remembered. But his renal function was improving, liver function was improving. His stroke peaked at 220, and he was on telemetry for 5 days after the event. So I saw, just to, as I said, continuing, I saw him in Advanced Heart Failure Bridge Clinic with Dr. Ranowitz that happens to be my clinic, and he's doing great. He's not playing hockey. He keeps asking about playing hockey. But he's back to work, light work. His EF recovered to 45 to 50%, not normal, but, and he's an appropriate medical therapy for heart failure, doing really well. So this was the first case that I had that I want to share. So case number 2, also that weekend. They're not necessarily in order as they presented, but I put the ECMO, the 2 ECMO cases first. So this is a 27-year-old female. She's previously healthy. She's 31 weeks pregnant. And we got a call that it was a Sunday morning, transfer from St. Cloud, and they say this patient has endocarditis, acute AI. We're transferring, and the reason is because of the baby support. So she's a PA at the medicine clinic, Central Care. So no family history of premature coronary artery disease, and there's no family history of valvular disease that she could tell us. No surgeries in the past either. So when she arrives to the hospital, her blood pressure is okay, but the diastolic pressure is a little bit low, consistent with AI. Heart rate in the 116, and she's a little bit hypoxic. Talking to her, she's in mild distress, a little bit anxious about the whole situation. She's a PA, so she knows what's going on. She has bilateral crackles. She's tachycardic. She has a diastolic murmur. No elevated JBP, and she's pregnant, but her exam is otherwise unremarkable. So we're real proud of the first test we did as an X-ray as cardiologists, and we saw that she clearly pulmonary edema, explaining her relative hypoxemia. So we diuresed her, and her O2 sats got better. Her EKG, when she came, she was tachycardic. But other than this sinus tachycardia that she had, we didn't see any abnormalities. So it was nice because she, you know, when we have a patient that is transferred, they always have the CDs and they come in a packet. She had the CDs in her hand and said, please, here are the CDs, and she gave us the CDs. And this is the echocardiogram from St. Cloud. So this 3-chamber view, clearly the severe AI. In the peristernal lung axis, we can see that there's the vegetation in that aortic valve that is pretty destroyed. Just markers of severe AI that we saw. She had diastolic flow reversal in the descending aorta. And for the echo persons, when we measure, when we have a CW across the aortic valve, we can calculate the LVDP in a non-invasive way if we know the diastolic blood pressure. So the velocity here at the end, the end diastolic velocity through this Doppler, we note that value that it was 2.9 meters per second. We got a LVDP of 18 millimeters of mercury. That for a healthy heart with an acute raise, it was pretty significant for her. This is a TE also from Central Care. She had a normal LV function. That was something that we noticed right away. Severe AI, and the other finding that we saw here is that she has diastolic MR. That is another finding of severe AI. So MR, if we have MR is present in systole, but here the regurgitant jet is so severe that it goes back during diastole. So a better view of the aortic valve. with vegetations. Something that we looked at right away that we discussed it with CV surgery is that the root doesn't look large, or there's no evidence of infection around the aortic valve. It's just involving the aortic valve itself. There was discussion in this short axis if we were dealing with a bicuspid valve or a tricuspid, but at the end the consensus was that it looked bicuspid, and per the surgery report it was a bicuspid valve. So now what? This is a Sunday night, and what do we do now? It is like we have a pregnant lady, very young, severe eye, with a basically, if it was a non-pregnant patient, he or she will be in the OR like immediately. But we have, she's not at her complete gestational age. We are thinking about how we deal with the baby as well. So we consult maternal fetal medicine, Dr. Fairbanks, and we had two questions for her. One is like, can we proceed with surgery? I mean, it's not, can we? It's like, we should. The question is like, should we do it now, or can we wait a little bit from her perspective? And then the second question was the antibiotics. Can we use any antibiotic we want, or should we use something that you can guide us? So she said, okay, let's start with betamethasone, 12 milligrams to mature the baby's lungs, and then we're going to do a C-section for sure. We also consult CV surgery, and also the question was the timing of the surgery. So I think this was very valuable also for me, because I was in a room with a young patient, the husband, both her parents, and then that Sunday night we had a maternal fetal medicine doctor, a CV surgeon, a cardiologist, and an ID doctor in the same room, and a cardiologist in the same room, talking and making the decisions and discussing with the patient. So we said, okay, this is our plan. We're gonna wait until Monday. We're gonna give her 1 day. We're gonna move her to the ICU, and we're gonna do the surgery Monday morning. We thought it was better because there were gonna be more support. Everybody was gonna be here, and part of the discussion, because of cosmetic reasons, she wanted a small sternotomy. And then obviously the question about bioprosthetic and mechanical valves. This created a lot of discussion even between like the providers and the family. But she was very clear that she wanted another baby, and she decided for a bioprosthetic valve. We told her that probably she will need a redo surgery within 10 years is what we quoted her, but she was pretty clear about the bioprosthetic valve. She didn't want to deal with Coumadin during her second pregnancy. So Monday morning, this is your EF now, okay? This is a TE in the OR. So now her EF is 20%. And this is just like 10 hours when she presented within the first echo that we saw from Central Care and Monday morning. So clearly endocarditis with a pretty bad EF. But we need to go proceed with surgery. And in the OR, we start with the C-section. Immediately post-delivery, she goes into ventricular fibrillation, 30 minutes of ventricular fibrillation. And I was so involved in this case that I went at the beginning of the OR, the beginning of the surgery, and when I walked in, they're doing CPR. So Dr. Sun goes down, he does a cut down, but she's in so much rocket fuel, as he will say, that her artery is so clamped that he cannot go up with a wire. So everybody is very stressed because we have a patient, we have a baby that is already delivered, baby's out of the OR already on his way to the NICU. But we have a patient on ventricular fibrillation, we're doing CPR, and we cannot advance a wire through that femoral artery because the femoral artery, she was a small lady, but her femoral arteries are like a pen, like of a pen. So after 30 minutes, finally, we get the wire up, and she's on ECMO, and her small sternotomy became a true big sternotomy, obviously, because this became an emergency. So Dr. Moody is going to help me a little bit with the surgical details, but so when they go in and they open the heart, Dr. Sun does the sternotomy, her LV is severely distended. So what they put is LV vents. So the first one went to her right superior pulmonary vein, and they're sucking blood at 1.5 liters per minute. And despite doing this, it's still distended. So he goes to the pulmonary artery. He puts another vent, additional 1 liter of decompression is given, and despite this, the heart is still big. He cannot proceed with the surgery with this distended heart. So he makes the decision that he needs to cross clamp and do cardioplegia. And as soon as he did that, the heart shrunk, and he proceeded with the AVR. Once he did the AVR, this is her EF. In the OR, she had normal sinus rhythm afterwards, but we cannot wean her off cardiopulmonary bypass. So we leave her on ECMO, and we put a central LV vent. So, Dr. Moody, I don't know if you want to comment a little bit on the surgical details, something that I missed, or the decision making.
Yeah, when you mentioned after sternotomy that the right superior pulmonary vein vent is placed, and additionally the PA vent, that obviously is done after full hyperinization and patient being on cardiopulmonary bypass with complete drainage of the right side and emptying the heart to the cardiac reservoir from the operating field, which basically just also shows that LV distension with a complete drainage of the right side can happen, obviously here secondary to severe or torrential AI, and even venting through a pulmonary vein with such high flows is may be insufficient, and the PA vent, because of probably already complete decompression of the right side from being on cardiopulmonary bypass, PA vent doesn't add much, and the severe AI is really what can injure and damage the left ventricle. Did you want me to comment anything about the decision making, or this is something for the discussion?
We can leave it for the discussion. But how about LV vent? So,
well, this is clearly the acute left ventricular failure. It's either post-cardiotomy shock syndrome, probably on top of acute LV damage from acute severe AI that happened day or days before. And then repairing the severe AI with AVR was not sufficient to wean her off. So obviously that decision on temporary mechanical circulatory support is appropriate, and LV decompression seems to be beneficial here, provided LVEF is very low. So obviously that's the right thing to do.
Perfect, thanks. So a little bit of schematic. So this is a quote unquote regular ECMO cannulation. So if this is a femoral vein, this is a drainage cannula, goes to the pump, the oxygenator, and then go back to the patient through the femoral artery. In a configuration like she had peripheral ECMO cannulation, but she had a central LV vent. So basically, we're draining blood from the LV to the vein, and goes to the pump and back to the oxygenator, and goes to the back to the patient and the femoral artery. So the rationale that we do this is because we are reducing the wall stress, so we reduce the afterload, and we have an unchanged arterial elastance, so that this creates a more efficient heart and provides a better unload. So her hospital course, she was decannulated by vascular surgery within 24 hours. She was extubated in 48 hours. She had the bioprosthetic AVR, and As I said, it was a bicuspid valve when we saw it, and she grew a strep mitis from this. That was pretty interesting. So we saw her in the Advanced Heart Failure Clinic, Bridge Clinic as well. She was doing really well. She was finishing the course of antibiotics. She was on guideline medical therapy as well because her EF was low normal. Dr. Sun saw her again recently on the 13th of this month, and she was happy to tell us that the baby was out of the NICU, still hospitalized, but doing really well. And she, other than getting a little bit fatigued with some of activities, she was doing really well and in good health. So that was the second case. So now I want to share a little bit of the experience that we have here at MHI with our ECMO data. So we perform a retrospective analysis of patients that had refractory cardiogenic shock. They were managed by ECMO between 2012 and May of 2016. So a little bit of the demographics. So we reviewed 129 patients, and so first of all, we divided by VA and VV ECMO, and overall death or overall mortality of these patients is 62%, and the VA ECMO has a better survival of 64 versus 56% on patients on VV ECMO. The length of stay, it's pretty similar within the two groups, but the interesting thing is that patients on VA ECMO are usually on less time on ECMO support, but the length of stay is really similar on both groups. As I said, outcomes, the mortality between VV and VE ECMO, and what I want to show here is the time of ECMO is pretty significant higher on VV ECMO patients. So then also the outcomes by etiology of shock. So the first patient, for example, is acute MI. So these patients have the best survival here at MHI. So they have a survival of 75% to discharge. And they're the patients that only 5 days on ECMO support, like our first patient, came acute MI, refractory cardiogenic shock, and placed on peripheral ECMO. The patients with end-stage ischemic cardiomyopathy are the ones that have the lowest survival to discharge, and these are patients that are chronically sick. And a little bit of the two exact patients that we had in terms of their mortality is pretty similar, between 55 to 60% post-cardiotomy with peripheral ECMO cannulation and post-cardiotomy with central ECMO cannulation. And here I want to share the patients that are on VA ECMO that went directly to bridge to LVAD. So we had 15 patients within that period from all the VA ECMOs that were reviewed. There were a total of 111. And post-cardiac arrest, because we definitely have patients like that come with a fresh cardiac arrest, acute MI, that the AV doesn't recover, so we put them on. We try to do a bridge to LVAD directly from that. And usually they have peripheral cannulation. The majority of them have peripheral cannulation, with a length of stay that is quite significantly different because convalescent period after an LVAD could be extended. And then I want to finish with the third case that this didn't involve an ECMO, but it was also very interesting. The same theme of pregnant patients during the same weekend that was pretty impressive to me. So this is a 39-year-old female, 36-week pregnant. This is her third child. She was watching TV at home, and she presented with chest pain. She said that something was sitting on her chest while she was watching TV. And we got a call from the ED saying, we have this patient. What do you think is the best stress test that we can do? So we're like, well, let's talk to her more. And then they didn't have the troponin yet when we got the call. They were waiting for the troponin that came high at 0.4. So we thought, well, let's do an echo first. So in the echocardiogram, she had wall motion abnormality in the anterior anterolateral and apical wall. Her EF was low, 45%. A little bit more of her history. She has hypothyroidism and obesity. She's also struggling with some gestational diabetes. She has a very strong family history of heart disease. Her dad had his first MI when he was 39, and he died of CV complications when he was 45. She doesn't smoke, no drugs, and husband is there, very supportive. So we see her vitals are pretty good. Her exam is pretty unremarkable. She's very comfortable. And after some nitro, her pain improved quite a bit. So I said her troponin was 0.452, but we didn't have that initial data when we got the first call. So this is her EKG on arrival, and we can go through it. So she has normal sinus rhythm, and we look very careful about, like we have this pregnant patient. It's not, she's young. Obviously, we have to have acute coronary syndrome in our differential, but is there something else going on? Pericarditis, other causes of chest pain. So we didn't see any she has ST depression here in the anterior leads, but at this point we're not going to let her go and do a stress test as an outpatient, but we were not clearly convinced that there was something going on with this EKG. So we wait a little bit, and this is 2 hours after she came, and we start seeing that the T waves start to change. Her ST depression is a little bit more marked, and at this point we got the echocardiogram as well that had the wall motion abnormality. So also extensive discussion, decision making, what we should do. We have this patient that has had typical chest pain resolved with nitro. We have some EKG changes. We had a positive troponin, and we have wall motion abnormality on the echocardiogram. So she clearly has, by all means, the definition of MI, that she clearly has a coronary event. So we call OB-GYN, maternal-fetal medicine, and interventional cardiology, and the person that we're in night call. And questions were, is radiation safe for the child? We went to radiate this kid. If we're going to take her to the Cath Lab, is heparin safe? Can we load her with aspirin? Can we load her with, in case we're going to do an intervention, can we load her with Plavix? Also important in the decision making is that she already was scheduled for her C-section in 4 weeks. So if we were going to put a stent, how they're going to proceed with C-section. So all those things came into the discussion, but we finally made the decision to take her to the Cath Lab. And so in this view, we can see that the LAD there in the proximal part has something. We didn't want to commit to atherosclerosis. Looks clearly, the other vessels clearly look like atherosclerosis, but is this like dissection? Is this CAT? We're thinking, is this pretty bad vasospasm in terms of endothelial dysfunction? So we should, the other coronaries, as I said, the other views, which clearly has evidence of coronary artery disease in the other vascular territories, and that we call it the culprit later. So we proceeded with a PCI, and then in the Cath Lab, the discussion was if we're going to go and do the PCI, are we going to put a bare metal stent versus drug-eluting stent? This was all discussed with the patient and MFM. Drug-eluting stents clearly have a better evidence for long-term, not as much restenosis as bare metal stents, but if she has a C-section planned in 4 weeks, we can do a shorter course of the clopidogrel. And then if we're going to use that, should we use the ticagrelor or prasugrel? Is aspirin okay? So all those things that came into decision making. Should we give her steroids? All those things came. So at the end, we decided for a bare metal stent because this is a minimum of 2 weeks of the APT. Optimal 4 weeks is what we told the patient. The restenosis rate as we have. So after the PCI came, we met with maternal fetal medicine and OB-GYN, and we came to the decision we're going to do 2 weeks of Plavix. We're going to have her a week off the Plavix after these 2 weeks. We're going to have the planned C-section, and OB-GYN said we're going to do a vertical skin incision because apparently, per their literature, there's less bleeding associated with this. We did an IVUS, and I'm going to let this run here, but basically this shows clearly severe atherosclerosis around in the endothelium. And then when we go back a little bit further, we see the normal artery. So we were clear that we were not dealing with a dissection or just a spontaneous or vasospasm. It was clearly coronary artery disease. So it was part of the reason that we intervened. So acute myocardial infarction associated with pregnancy is something that, I mean, all this in a weekend was too much, but it's something that we don't see very often. But I found that pretty much all the patients that these guys reviewed, they all had the ACS. The majority of them had the ACS during pregnancy. Pretty young patients as our patients. Anterior location, the majority of them, that was pretty interesting. Like the majority of the MIs happened in the anterior distribution. Coronary, when the coronary anatomy was available, the majority were from stenosis from coronary disease. Some of them are from dissection as well, or clot. And mortality is not too high. And this review is from 2008, and they went back to 85. So I think it should be even better now that we have more interventions and more things. So basically, as we discussed, I found this review on management of acute coronary syndrome during pregnancy. And basically, to summarize a little bit, is they're pretty emphatic that we should treat these patients as we should treat any other acute coronary syndrome patient. The only caveats they give is we should not use ACE, ARBs, and no statins in a pregnant patient or a patient that is lactating. So a little bit of the follow-up. Her follow-up is pretty unremarkable. We didn't put her on statin despite an LDL of 190. That made us a little bit uncomfortable. But it was instructions that we had from our consultant docs. So her EF normalized. Remember, her EF was a little bit low. And then she came for the C-section 4 weeks later as planned. And then during the induction of spinal anesthesia, she became really hypotensive. Her blood pressure dropped to the 50s. She had some EKG changes. Obviously, they call us right away. But thankfully, we repeated an echocardiogram. There were no changes from the ones we had in her EKG normalized. So we didn't have any like acute concerns for acute stent thrombosis or any of that, like despite her drop in blood pressure. So this is what I have for today. Thank you so much. And then I don't know if there's any questions or comments.
Very nice job with the 3 years and the talk. Nice work.
Thank you.
Question, and in general, if you're in the OR and making decisions, and this is for anyone who wants to answer, and have a lot of experience with ECMO versus I don't have a lot of experience, but I know how to place a cannula and then I can send a patient. Should that affect people's decisions up front, high-risk patients prior to surgery going to a place that has experience versus sending them after they have a problem with cannulas in place?
You answer first?
I don't know if it was directed to me, but which case are you referring to? Any case, yeah. Yeah, I mean, I think it's kind of a rhetorical question, and thank you for that question. I think that obviously proactive rather than reactive approach is much better in those high-risk patients because we, with current, I think technology and what we can offer, the actual risk of planned, even high-risk cases, the perioperative mortality is extremely low nowadays when you actually look at populations of patients we operate on that sometimes come to us in multi-organ failure secondary to cardiogenic walking shock, and those patients have excellent results. So I don't think that patients that have some kind of an acute situation like valvular structural problem in pregnancy should be offered anything less. I think they should be actually offered more. And my comments to the second case that Dr. Miranda asked me to kind of be present for is that I have two comments. That thank God for young patients because they can take any situation they're put into. And the second case is that the second comment is that there really is a reason why every single cardiac surgery textbook describes severe acute AI as surgical emergency, and this is something that a few of my professors in my training really made sure that we understand that there is no stabilization of the acute severe AI. And I think that the excellent example here is that the EF on the first echo is pretty good, and few hours later the same ventricle looks terrible. And the next thing that happens in any type of disturbance is that a patient arrests and patient cannot go on acute mechanical support without surgical intervention. So we put the LV recovery, we give the chance for the LV to recover, we give it even lower chance, because if we place peripheral ECMO, that is the fastest, then we can really damage the LV permanently because of the distension and wall stress that can be irreversible. This type of damage wasn't here, thank God, and she did fine. I think that any stabilization that is required in severe acute AI is basically getting IV access, giving dose of antibiotics, and going to OR. That's really my approach. I think that also the reason I think that being in tertiary center requires us to think that Saturday night, Friday night, and Sunday night is just a regular working day, just like Monday morning, and there is the same resources. If we can do multiple redos, sternotomy, heart transplants with good results on Saturday night, we should be able to do AVR on Sunday evening. I think that's something that should be really expected from us. So that's just one thing. I think that potentially this case, I mean, there's obviously this case went well and she did fine and her ventricle recovered. Potentially, maybe getting to approach it a little safer would be to get a peripheral percutaneous access when she was not in shock, when she arrested, and then cannulation of the femoral vessels would have been easier, and then obviously placing her on ECMO puts her heart at stress, but within 15 to 20 minutes, patient can be sternotomized and heart can be decompressed with aortic cross clamp and opening the aorta. So that's something that is definitely something that left ventricle can take, but longer periods obviously are putting the LV at higher risk.
question. I think the venting is something kind of scary, but we have time. So let's say minus the AI, obviously AI is one of these situations where let's not think about ECMO unless, they can take them to the OR right now and take care of it. But other than AI, I think, if somebody is close to coding or coded, arrested, STEMI complicated by shock or anything else, I would say put on ECMO at your facility if you can, ship here, and then if they need venting or something, we still have 6 to 8 hours, to place it safely. But I wouldn't say, if you can, don't put patient on ECMO because you might need venting. Because I think that was also your question, right?
Yeah, I think it has to do with the pre-planning. So if someone has a high likelihood of requiring ECMO, would you make the decision to ship them from a peripheral hospital for the initial surgery here versus do the surgery, place the cannula, and then send?
Well, I guess it depends on the surgery, but I would say if you think somebody has, let's say it's Duluth, let's make it this way because we actually do get transfers from Duluth. You feel somebody is, sliding in Duluth. They can put patients on ECMO. They do it very well. Put them on ECMO and send them over. That would be because, then, we have time. They're safe. We have time. They need surgery. They need venting. They need whatever. They need an LVAD down the road. They're here. But I think it's easier to put them on ECMO, ship them over. We can even deal with complications, They'll be fine on ECMO for like 3 hours for the transport, and we have those capabilities.
Any other questions?
Excellent job, Dr. Miranda.
Thank you.
In the third case, there was a lot of discussion and debate about bare metal versus drug-eluting, holding Plavix, et cetera. Was there any thought from the obstetrics team to plan a C-section on aspirin and clopidogrel as opposed to exposing the patient to the risk of holding the clopidogrel in the acute phase?
So yeah, that came, and that's why they were thinking about doing the vertical incision. So they, the preferred way that they said is to hold the Plavix because they apparently, from a surgical standpoint, it's very significant bleeding. But they said that if they wouldn't be able to hold the Plavix, they would do a vertical incision for the C-section. So that was a possibility, but everybody agreed that it was like the less preferred approach. But yeah, that came up.
Was there any quantification of the bleeding risk or estimation of the bleeding risk on both agents?
I don't know that. No.
Anybody else? Okay, thank you very much. Please stop by and thank our session sponsors, Lundbeck and Rob Arneson and Jillian Hendrickson from Pfizer. Have a great day. Have a great week.